I get to talk about something I don't often get a chance to talk to you folks about, and really I'd like to thank Michelle Hepburn and the 3C Foundation for really making this possible for us. Today I was going to talk about some of the research. There's a lot going on, but I was going to talk about what's happening, you know, directly at Children's Hospital. I'm trying to put a little context on it, and the topics. There's a lot of topics. We put up a display just on the outside with some of the you know, medical manuscripts that came out last year. So there's quite a bit going on. And I think the first one we want to talk about is this Crohn's disease, and it's increasing. And that's kind of like a wow thing going on. A little bit about the genetics, some of the treatment changes that are, you know, having profound effects. So it's not just esoteric research, but we're actually taking it to the bedside and making a difference. Some of the outcomes and really what's on the horizon. So, you know, what's known about this IBD in children? Well, first off, it's common in Canada. You know why? No one's really all that sure, but it's one of the highest in the entire world right now. And for all the people that develop IBD, a quarter of them are kids now. So, you know, this isn't an adult disease. I mean, this is hardcore in children now. And I think the other thing you've heard a little bit about when Dr. Ward was talking, but in these younger people, it's more extensive parts of the bowel are involved than in adults, and it's way more aggressive. So what's new? And this is work actually that Dr. Benchimol did in his fellowship. So I guess we kind of got him interested in this GI stuff when he was a resident at CHEO. And he went down to sick kids, not only to do some training in medical training, but he actually did a PhD. And his major study was what's happening, you know, with this disease. And so he was able to pull all the pediatric centers in Ontario together in one of the best evidence in the world right now. And that included, you know, CHEO. And the shocking things is since 1995, there's been a 5% increase in inflammatory bowel disease in 0 to 4-year-olds. And a 7.5% increase in the 5 to 9-year-olds. I mean, that's incredible. To put that in perspective, a colleague of mine who was at Mayo, who retired a few years ago, when he first started, he said, I hardly ever see this thing. I mean, this week alone, we've got 5 new kids we're dealing with here in Ottawa. I mean, it's out of control right now. And these are really sick kids. I mean, these are really sick. I think we've been doing a lot of studies in genetics. I thought, you know, there was one time back then when they thought there was going to be 1 or 2 genes involved in this thing. We've been heavily involved with this over the last 8-9 years, so there's now 100 genes involved in this thing. That's mind-boggling. Some of the genes, you know, are associated with different conditions. So rheumatoid arthritis, Crohn's disease, well, I mean, that's just befuddling to genetics people. So it was always thought, 1 gene, 1 disease. Well, that's out the door now. So it might be helping us to sort of look for new treatment things, but that's pretty tough to deal with right now. So cure's not on the horizon, but we're learning more. We thought maybe there was some unique genes in kids because they're so sick when they come in. Not true. The genes are the same as in the adults, so that was a little bit of a shocker. They don't really predict outcome now, and they don't really help in diagnosis. So, yeah, but it is opening eyes, so we're sticking with it for now. And then what's really a little bit scary is that there's this kids that are really under 3 years of age with almost untreatable Crohn's now that are showing up. So one of our colleagues in Toronto that we're working with is finding some very, very unique, you know, kind of changes in these kids. So we're trying to see just how prevalent that is, you know, with all of our younger kids. And when he first called me and we were talking about this, he was looking for kids under 10. And I thought, you know, I probably got a handful, you know. So we've been going through, as everyone's coming in, we're looking at it, and I think about 20% of our kids are now diagnosed under 10. I mean, that's like mind-boggling. I remember a few of them really well because they were like under a year of age, and I thought, no, there's no way, right? So we're learning. It's not good learning, but we're learning. So what about ulcerative colitis in kids? You know, unlike the adult world, in about 80% of the kids, the entire colon's involved. Like it's just right throughout. And that's pretty unusual in the adult. About a third of them, you know, are in the hospital at least once for really severe disease. I mean, that's shocking numbers, right? And about 40%, you know, the old days, about 40% of those that came into hospital with severe UC didn't respond to intravenous corticosteroids and you know, had colectomies. So, you know, what have we learned? And this was a multi-center study, and I think it's changed our practice in the last 5 years. So we now know that those that don't respond to the steroids, it's not because of the dose. We, you know, when I first started in this, we used to say, well, you need to use at least 4 weeks of steroids to make sure it didn't work. And then it's cut down to, you know, 2 weeks, and now we're down to about 3 to 5 days. So now at 5 days, if the IV corticosteroids haven't helped, the longer time doesn't make a difference. What it does do is make, you know, more risk of surgery after. So our surgeons want less and less of this, and we're in total agreement. So you're seeing now this infliximab come in, or Remicade, you know, is a trade name for it. And for those severe ones, we're starting up on day 5. So this is, you know, you would never hear about this 5 years ago. We're down to about 20%, so it's about half the colectomy rate. Do I think we know exactly how to use Remicade yet? No. It's clearly not the same as Crohn's disease. And we're working on, you know, trying to get the exact right dosing of it, but it's an aggressive disease at times. What about Crohn's disease and this Remicade? So, you know, when this first started up in the mid-90s, you know, you're talking about 60%. It was all in adults. They'd all been on all sorts of other drugs. But in kids, it's about 80% effective, Remicade, in Crohn's disease. We're doing a lot more with the inflammatory phase than some of the chronic changes. So those are good numbers. I mean, those are good numbers. It's not a cure, but it's coming along. So one of the, you know, I think quite a few people are involved in this, and these are these groups that are getting together now. And I think, you know, I think there's probably 2 great things at CHEO when I look across the rest of the country and down to the States. And one is our hospital has really been supporting the idea of providing a program. And I think that the program is not just medicines, but we need to think about nutrition and psychosocial. So it's a total. So we have the support from CHEO to do that. And I think the other thing is we're involved in these large multi-center groups. So these have been a few major centers in Canada and tying up with large American centers. So there's not that treatment differential anymore, you know, one center to the next. And I'd say these are becoming so powerful for learning that there's a lot of interest now in getting across Canada one as well. And so we're hopeful within the next year that'll be happening. So this one group we're in is 3 centers here in Canada, excuse me, 18 in the US, and they looked at about 750 kids with Crohn's, all new, and about over 200 of them needed the infliximab or Remicade. You know, these kids are always the sicker ones. So over a 3-year period with this medicine, you know, still about 2/3 of them are responding. So that's pretty good for long-term maintenance. A little depressing when you think you've got this disease for life. We need to learn more. And you have to adjust the doses. So it's not something that I think is going to be good for all kids for a long time. But in this age group that we're trying to go through puberty, where this immune system is really changing and super aggressive, if we can get through this, then a lot of times at the end, by the time they go over to the adult years, they get these enormous transfer, wad of papers, and the kids walk in and say, hey, I'm okay. So there's hope, and I think we don't have a cure, but the hope is to get through, these childhood years. So what about this Humira? It's out in adults. The pediatric trial has been done. It's with Health Canada and all that kind of stuff. And we use it really after the Remicade is not working. And the adult studies show about 40% that have lost response to Remicade will respond to this Humira. So our group then, there was 2 Canadian centers and 10 in the US that have been using this medication, and about 115 total together. So to me, that's way better than, what's our experience at CHEO? We have 15. Well, that's nice, but I like to see numbers over 100 because it tells us more information. So the first dose is usually 5 years after diagnosis because we're going through other medications. Most of them had Remicade first. So 70%, still seeing a response in the first year. So double that of the adult groups. So again, we're dealing with more inflammatory, not all the chronic changes. There's hope that we've got other medications. So one study that we actually had a pediatric resident there, training to become a pediatrician, and Anna Kapinska, and she said, is there something, I can't do those multi-center trials because I'm only in my training for 3 or 4 years. But is there something we can look at that might make a difference? So methotrexate has been more commonly used in Crohn's disease. And in the literature, about 2/3 of them, they didn't take it too well because they were getting nausea and vomiting. And there was a lot of things being used, ginger and Gravol and all those other things. So we started using on Dancitron after talking with our leukemia colleagues because they use a lot of methotrexate as well. So we got a protocol from them, and we've been starting them to use it before they develop it. And really, I guess, that terrific response with this, that 80%, 85% don't develop it. We only need to use it about 4 to 8 weeks, and they never have it. Whereas if they don't use it up front, get this trouble, it doesn't work as well. So we've got, experts like that, but we're trying to get these new generation of people interested in this IBD as well. So what's going on right now? We have the registry, that's the different centers, that's out 10 years now, so we're getting some pretty good data. The JUMP study we've heard about, that's really looking, and some of you may be involved, that's looking for the healthy brothers and sisters of people known with Crohn's to see if there's any predictors that can see, who's going to develop it. There's a risk study that's centered out of the US, and they have us involved in that as well, the Crohn's Foundation of America. And what it's trying to do is look for predictors for outcome. Now all we're dealing with is, okay, you've got the disease, this is involved. We use percentages, but what I really want to know is the individual, like individualized medicine. So 1, we don't undertreat, or 2, we don't overtreat. So that's hopefully in the next 5 to 7 years we'll have data out on that. Bone health studies, you heard Dr. Ward do that. We've heard some of the psychosocial from Mindy, but Dr. Cohen's working on that, and what we want to do is try and predict how the kids are going to cope, to get an easy mechanism to ask questions, to figure out how they're going to cope and how they're going to do, so we don't end up in crisis management. That's the worst thing, is if things are falling apart and trying to deal with it then. So again, prevention. And one of the things that's really heavily going on right now is what we call the microbiome study. And it's kind of an interesting thing that, I'm standing here, but all the DNA in my body makes it, the human part is about 0.3%. The other 97.7% of the DNA in our body is the microbes in our gut. And all this stuff is completely interchangeable. And for a long time, all therapies have directed just at the human. But you know, this huge amount of DNA that's right close up to the biggest immune system in the body, the gut, has been largely ignored. One, there was really no way of studying it until the last few years, and now they've got incredible, powerful ways of looking at this. So what we do is you know, during a scope, just get a little bit of that fluid that's right at the interface. Instead of just throwing it out, we're sending it off now. And we've got the Canadian government is funded this to a huge level. And the biggest thing we got with this money the first year was this supercomputer, because the amount of data we get from a single patient now is just gigabytes. So we don't hire biology students anymore, we hire computer analysts. I mean, it's like the color graphs they put out for that is like amazing. But I think, you know, some preliminary stuff on this that we're going to be presenting at one of the big meetings is there's not a single bacteria, but a group of metabolically active bacteria that if we put it in a germ-free animal develop inflammation. I mean, that's shocking, right? So something's happened to change the metabolism of these microbes in there. We don't even know which ones they are yet, but there's a whole group of them. So I would say, you know, hold on. There's a lot of stuff going to happen over the next 10 years. I don't think these will be cures, but I think they offer different and possibly, you know, less harsh treatments. We're just working on getting a couple other studies going. You know, nobody likes the scope, right? I mean, maybe they like the anesthesia to fall asleep, but, you know, so we've got this this new technique that our radiologists have helped us over the last year. It's kind of like, I guess it's, you know, the old was the barium, you know, follow through, and it's kind of like hockey, you know, you're looking at the old analog TV and it's that fuzzy white stuff there. This MRI neurography is like a HD TV. I mean, it's incredible stuff. And there's I guess a group from Australia and Sick Kids and us have developed this technique. So we're pretty much getting away with barium studies anymore. I think that's good. Not only better visualization, but less radiation, ionizing. So then we're going to try and compare that with scoping and a new stool test we're developing. So maybe we'll get a little bit less invasive for testing. New standards of care for ulcerative colitis. This study is going to be up and going probably around June or July. And this is the very first pediatric trial that's starting to look at what's the optimum care that we know in 2012. And that will be then the basis for all other care in the future. It's got to meet, well, no, it's got to exceed what we're going to do. So incredibly important study that we're going to be involved with. And then I think there's a real chance that we may get a Canadian-wide network. And I think that's important because there are differences, you know, with the healthcare systems between the US and Canada. And I think it's really important to be involved in some of those. But I think at Canada-wide we can do some very other key things that are not available right now. So really, I think really the thanks is to all the parents and the kids especially, for, you know, giving up their time and all the crazy samples we keep asking for. This is just a small little thing of what we're doing with all that research work we're doing here at CHEO, and I think it's offering us the thought that we might get better in the future than we do now, and there are some tangible differences that we're seeing in care. And I think, you know, theory is great, better for the kids is better. And with that, thanks.